Today I'm going to talk about asthma. Asthma is a very common condition and affects about 300 million people globally. It is a condition that is likely to appear in your exam. When we think about asthma, we think about two key terms, reversibility and obstructive. Reversible differentiates it from COPD, which is an irreversible condition, and obstructive means its FV1/FVC ratio will be less than 0.7. In asthma, there is inflammation of the airways, which gives the classical bronchoconstriction. This means the airways are constricted or narrowed, and as you can imagine, this would give wheeze, breathlessness, and chest tightening. But this bronchoconstriction is episodic and reversible. Sometimes it occurs and sometimes it doesn't. And when it occurs, it is due often to airway hyperresponsiveness. This is when there is an exaggerated response to things like cold air, exercise, and allergens, which people without asthma do not have this response to. And then, of course, this will give bronchoconstriction. And what causes asthma? Well, it's multifactorial, genetics play a part, and the environment. Also, patients who have a history of atopy and have conditions like eczema and hay fever are more likely to develop asthma. So it's important to ask about this in the history, as well as if they've pets at home. Hygiene hypothesis postulates that if someone has not been exposed to infections in their childhood, they are more likely to develop asthma due to altered T-cell function. So, in a history, you could ask about things like that. In asthma, there's bronchoconstriction of the airways, which gives the classical wheeze. But there are also other symptoms like the tightness of the chest, the breathlessness, and the cough. And also there'll be variation from the morning to the evening. For instance, asthmatic patients will have more symptoms in the morning. And to monitor this, patients are often given peak flow meters to bring home and to breathe in the morning and the evening. And they'll see that in the morning the patients won't do as well with the peak flow meter. So diagnosing asthma, clinically we need to point it in the right direction. So is there wheeze? Is there chest tightness? Is the patient breathless? Is there a variation from morning to evening? Do they have a history of atopy? Have they never smoked? Is the other diagnosis is very unlikely? Is there a family history of asthma? Have they pets at home? Have they carpets? Does it come on at work? Is it occupational asthma? And then we do tests like spirometry, and this measures the forced expiratory volume in 1 second over the forced vital capacity, and if less than 0.7 it's obstructive, and high levels indicate restrictive lung disease. Then, because obstructive disease can be COPD or asthma, we use a bronchodilator. If it improves the FEV1-FVC ratio, we know it's asthma. Peak flow, as I said before, they take home, they use it, it shows variability. Skin prick can be used to show atopy, and the challenge test has gone out of fashion as it's quite dangerous to do. The fractional exhaled nitric oxide is becoming more popular to do, and more common in fact. So when do you suspect eosinophilic granulomatosis with polyangiitis? Well, this is a vasculitis condition of small and medium vessels, and it is suspected in patients who have asthma for more than 10 years, and they have a lot of eosinophils in their blood. Now, in terms of management of asthma, we would use SABAs originally, then SABAs and inhaled corticosteroids, and then we would move on to other steps adding in the LABA in the 4th stage. Asthma can be divided into Acute asthma can be divided into severe, life-threatening and moderate. And we need to know how to deal with these conditions because they're very important, and asthma can be life-threatening. So we use the Abcde approach. First of all, we check, are the airways open? And if not, you should do some airway maneuvers to ensure the airways are open. This is very important, and it's important to get an anaesthetist early if you think the patient is peri-arrest. Also, in breathing, you should check the respiratory rate. You should check the oxygen sets. If they're low, apply oxygen. You should do an ABG to check the PaO2 and the PCO2 and see how sick the patient is. The lactate also will be shown, which is a very good marker of how acutely unwell the patient is. It is advisable to give salbutamol 5 mg nebulized and to repeat that every 15 to 30 minutes. You should also give ipratropium bromide 0.5 mg or 500 micrograms. Then in circulation, it's useful to check the heart rate, the blood pressure, the capillary refill time, to apply an ECG, and to check is the patient clammy. It's also useful to give steroids. You can give IV steroids such as hydrocortisone 200 mg or prednisolone 40 mg, and you should give the steroids for 5 days after. So if someone has acute asthma and they're still in hospital after, you continue that course of steroids for 5 days. Then you look at other things like the Glasgow Coma Scale can be done in D, pupils can be checked, and just in general their responsiveness and what drugs they're on, and just anything else that you think is significant. Magnesium sulfate 1 to 2 grams can be given over 20 minutes if a patient is very unwell after you have sought senior advice. And it's important to treat as you meet, so go airway, breathing, circulation, and treat as you meet and reassess. And contact senior help in acute asthma so the patient is managed as well as they can be. Thank you for listening, and if you've liked this video, please don't forget to click the like button and subscribe for more medical education videos.